Well, I would like to welcome everybody. It is an honor that you would join us. Just as a reminder for these conferences, we have the participants muted, but you can use the chat box to bring up any conversation. We also ask to mention that you're here in the chat box so that it's recorded for CME purposes. As we were brainstorming topics to present that would be relevant to you or referring medical oncologists and other referring doctors, uh, as well as an area that's been changing and really probably underutilized for radiation. Oligometastases came to the top. I remember in original days when I was in practice, it was really probably considered irresponsible to talk about treating metastatic disease as a definitive therapy. But this has changed quite dramatically with phase 2 data, sometimes over 20 years of data supporting treatment and even randomized studies. And so we collected this data and have two young whippersnappers who aren't held back by some of this history, perhaps, and just to give everyone a view of Dario Pasalic and Joshua Gruhl to hear speak about oligometastases. So welcome, and with that, I will transfer to Dr. Pasalic.
Thank you so much, Dr. Carter, for that kind introduction. Here's a quick outline of what we're going to be going over today. We'll start off with defining oligometastatic disease, go into the summary of the data, and then Dr. Gruhl will take it over with some detailed evidence and guideline-based disease site indications. We'll go through some available clinical trials at RMCC, and then if there's time, we can touch on stereotactic radiation capabilities at RMCC. So there's a lot of definitions out there. The estro-astro consensus is, an intermediate state between local and systemic disease, where a radical local treatment with primary cancer and all metastatic sites, that's important. All metastatic lesions might have a, curative potential. In practice, that turns into, anywhere from 1 to 5 lesions, although a lot of this depends on histology, systemic therapy options, and prevalence, absence of a primary. Getting a little bit into the nitty gritty, there are some specific definitions. When we talk about synchronous oligometastatic disease, we're talking about de novo disease at the time of diagnosis with active untreated primary. When we're looking at metachronous oligometastatic disease, we're looking at oligo recurrence, typically 3 to 6 months after initial diagnosis with a controlled primary. And an oligo progression refers to a few lesions that progress on the background of widespread but stable disease, and an oligo persistence, looking at persistent disease after systemic therapy. There's a good paper in Lancet Oncology that goes into more detail about this spectrum of definition within oligometastatic disease, and I have it here for your reference. And you'll see me often use these terms, in my consult note to kind of get a really specific about what we're talking about for each patient's scenario. When we talk about oligometastatic disease and when we're looking to choose radiation or other local therapies, whether it's surgery or radiation, I think there are some important questions to always ask ourselves. And in particular, it's, is there potential for improvement in survival or quality of life? A number of trials have shown that benefit with radiation and surgery. Does this patient have limited systemic therapy options? Radiation has the potential to remove resistant clones and allow for prolongation of systemic therapy or a delay to next line therapy. And then is there a sensitive or symptomatic area where local progression would cause significant morbidity in the future, where radiation has the potential to provide local, durable local control? We know this very well with brain, but also I think about things like supraclav and other critical locations around the body. So I'm not even going to bury the lead here. I'm going to give you the summary first of all the data, and then Dr. Gruhl is going to go into a little bit more detail about each one of these studies. So here's a 20,000-foot view of phase 2 and phase 3 trials in the oligometastatic setting. These are all randomized, and I've got them categorized here by oligoprogressive, synchronous, and metachronous. Green indicates positive trials, yellow is mixed trials, and then red is our negative trials. And here's a even more detailed summary of a lot of those trials. And the big picture here is many of them have been positive. Many of them have been phase 2, unfortunately, not phase 3 data. But there is a mix of PFS, OS benefit, as well as quality of life metrics such as ADT-free survival. I think the evidence is probably the strongest in lung and prostate, and we'll touch on all these trials as we kind of progress through the talk today. There are obviously guidelines that will summarize, a lot of the evidence for us. I like the ESMO guidelines because of the summary they provide. Brain mets is kind of the original oligometastatic site. There's a level 1 evidence for that. Lung, there's a level 2B indication for treating the primary and metastatic sites. Prostate, there's a level 1A recommendation for treating the primary and low volume metastatic disease. And there's more and more emerging evidence for treating colorectal cancer with metastatic sites such as lung and liver. I'm not spent too much time on this, but just want to show you that payers are on board with this. They do support, the use of oligometastatic or the use of stereotactic radiation for oligometastatic disease, and that's been, shown here through Evacor. What I do want to spend a little bit of time on is just talking about dose and fractionation, because we'll often talk about stereotactic radiation, anywhere from 1 to 5 fractions, and that's true. And we try to use stereotactic radiation whenever we can. And it typically is in locations that are away from critical structures. We're talking about peripheral lung, brain, liver, adrenal, renal, bone, pancreas. But oftentimes you'll see me recommend, 8 fractions, 10 fractions, 15 fractions. And even though it's not technically stereotactic, what I want you to know is that those are still very ablative radiation courses. And so much so that if you look at the chart here in yellow, an eight fraction course is the equivalent of about 105 gray, which is equivalent to about giving 50 gray in 5 fractions. So we tend to sometimes choose these hypofractionated but ablative courses when they're near critical structures such as bowel, bronchus, brainstem, biliary tree, where we have to spread out that dose over a little bit of a longer time period to protect those critical organs at risk. So just because we're not calling it stereotactic doesn't mean we're not doing an ablative radiation course. And I just want to give you an example from a popular trial. Dr. Gruhl will go over this later, the Gomez trial, which accrued patients at MD Anderson, at UCH, and at London Health. And they did this exact same thing, which is, stereotactic radiation whenever we could, 1, 4, 5 fractions, but they also did 15 fraction, 10 fraction. It all depended on sort of the location of those individual sites. And I do want to point out that, UCH contributed a lot of patients to that trial, and they have a very active oligometastatic program just down the road. Here is a meta-analysis of toxicity for stereotactic radiation looking at prospective and randomized trials. Basically, it goes to show that there's a 1.2% acute grade 3 to 5 toxicity rate and about a 1.7% late grade 3 to 5 toxicity rate. So very safe, on top of being very effective. In the era of EOM and value-based care, I think cost effectiveness is an important topic that sometimes goes under appreciated. This is an interesting set of papers that looked at stereotactic radiation versus, some forms of systemic therapy, looking at the quality adjusted life year, cost per quality adjusted life year. And it was about $29,000 for stereotactic radiation compared to, about $194,000 for pembro and chemo. So on this other chart here, you see that, the more metastatic sites you have, the less that cost analysis benefits stereotactic radiation and more that it benefits systemic therapy. So there's obviously trade-offs, depending on how many sites and lesions we're treating. So trying to summarize, who's a good candidate for stereotactic radiation? I think about, 1 to 5 lesions before or after systemic therapy. And that's something I want to really, hit home. We'll often see oligo recurrent, after a patient's been on systemic therapy for 1 or 2 years, there's a lesion that's growing, and we're happy to treat those too. But the preponderance of the evidence, when the way the trials were set up, is to show that, you start off with systemic therapy and then you consolidate with radiation as soon as possible to any, remaining remnants of soft tissue. So getting him in soon, getting him in early, I think does make a difference. Brain mets, we know this, radiation or post-op radiation is very effective. And we're now pushing the limits, with 5 to 20 mets. Dr. Richard, my partner, just the other day treated a patient with 26 brain mets. And, we feel very comfortable pushing that envelope now with stereotactic radiation as opposed to doing whole brain. Spine and bone mets seem to benefit from stereotactic radiation in terms of pain control and local control, especially in the oligometastatic and radioresistant setting. And in terms of, oligometastatic consolidation, I think the most robust evidence is in lung as well as in prostate, but there is emerging evidence, for stereotactic radiation in liver primaries, renal and adrenal, colorectal mets, particularly the liver and lung. And if you're ever in doubt, just send to us or contact us. We're happy to look at each case individually and see if they're a candidate. We have a lot of convenient locations for stereotactic radiation. Boulder and Aurora are kind of our two main sites where we can treat any and all, oligometastatic sites. We're pretty proud of having, I think, the most advanced technology on the market in terms of treating these lesions very accurately with minimal margin using the TrueBeam system and ExactTrack system. And we do have stereotactic capabilities at Littleton, particularly for bone, lung, and prostate. And we're looking at upgrades in Thornton for lung and bone eventually. So that's pending at this point. So I just want to delve into the CNS and bone met data really quickly. I think this is something that we're all familiar with. This is kind of the original oligometastatic site, the brain. And we know that there is a benefit, to treating brain mets, particularly oligometastatic, brain mets, 1 to 3 lesions with stereotactic radiation. R2G9508 and the phase 3 MD Anderson trial showed an overall survival benefit to that radiation consolidation. This is a very eloquent area where local progression can be devastating. What I want to point out to you is some more of the more recent data out of MD Anderson, looking at 1 to 3 brain mets that were completely resected with surgery, then randomized to observation or post-op stereotactic radiation. What they found was that there's an improvement in 1 year freedom from local recurrence with the addition of post-operative radiation, 72% versus 63%. So about 60% of the patients with surgery alone will have a progression even at 1 year without the addition of radiation. Just going to show that surgery and radiation can play a critical role here in protecting the brain from a recurrence. This is supported by ESMO and ASCO guidelines, as well as ASTRO, as well as NCCN guidelines. One other thing I want to hit on quickly is bone mets. These are trials that were not done in the oligometastatic setting, but I think it's just important to remember that these trials showed an improvement in pain control as well as local control with the addition of stereotactic radiation compared to conventional radiation for bone mets and spine mets. And so, I am a big proponent of doing stereotactic radiation for bone and spine mets. The main limitation right now is payers. Really, they only want to address this for patients with oligometastatic disease, not with polymetastatic disease. So, in many ways, sometimes we're limited by payers at the moment, but really an exciting area of growth and interest from a radiation point of view. And again, supported by guidelines. So I'm going to hand it over to Dr. Gruhl.
Thanks, Dr. Pasalic. All right, can you see my screen okay? Great. All right, so I'm going to first touch on a basket trial. A lot of you are probably familiar with this. So this is the phase 2 SABRE Comet trial. So this was one of the first oligometastatic trials. So this was done at 10 centers internationally. There were about 100 patients enrolled. They allowed all histologies, but primarily these patients were colorectal, lung, breast, and prostate. They allowed up to 5 oligometastatic lesions. They did allow brain mets, but not if they required upfront surgery for those. Most of the metastases were actually in the lung and bone, less often in the liver or the adrenal glands. And at the time of publication, this was the first randomized trial to show an improvement in overall survival when ablating all sites of oligometastatic disease. So again, patients with up to 5 oligometastatic lesions, they could have any tumor site. They had a good primary or a good performance status and a well-controlled primary site. They were either randomized to standard of care systemic therapy alone or standard of care systemic therapy and stereotactic radiation to all sites of metastatic disease. What they found was a really significant improvement in overall survival at 5 years, 42% in the group that got radiation for oligometastatic sites versus 18% that were treated with systemic therapy alone, and an improvement in progression-free survival. This curve on the left is the overall survival curve, and the right is the progression-free survival curve. This survival benefit persisted even when the prostate cancer patients were taken out of the analysis. And interestingly, you can see from this red line, this is the SBRT arm. And so a substantial number of these patients who lived longer than 5 years, about 30% of them needed more SBRT for new metastatic sites in the future, and that was allowed on the trial. I'm going to touch on oligometastatic lung cancer now. So there are really 3 key trials to know right now. And so this is the the Gomez trial, or often referred to as the Oligometastases trial, the Iyengar trial at a UT Southwestern, and then the Sindus trial. And so similarly, these all included non-small cell lung cancer patients. The Sindus trial, the difference here is that these were EGFR mutated only. All of them allowed radiation of the primary site in the lung, as well as regional nodes in the mediastinum. The difference, Gomez allowed up to 3 metastatic sites, whereas the Iyengar and the Sindus trial allowed up to 5. So first, the Gomez phase 2 multi-center trial. So this was published in 2019. Again, all patients, stage 4 non-small cell lung cancer, mostly adenocarcinomas. They could have metastatic disease in any location. So they had, the requirement was really to have up to 3 oligometastatic lesions with no progression after 3 months of systemic therapy. And they did exclude patients that had a CR to those 3 months of systemic therapy. So all of them got 3 months of systemic therapy. They were then randomized to either continuing on systemic therapy or local treatment to the primary in the lung and all sites of oligometastatic disease. That could be with either surgery or radiation. About 75% of the patients got radiation, the other 25% got surgery, and then they went on to get more systemic therapy after that. Most of these patients had synchronous oligometastatic disease, so really the primary and the metastatic sites diagnosed at the same time, de novo metastatic. Most were non-mutated. They found this left-hand curve is the overall survival curve, and the right-hand curve is the progression-free survival curve. So there was a pretty dramatic improvement in overall survival in the patients that got radiation to the primary and oligometastatic sites. It was 22 months as far as an overall survival benefit. And then there was a 10-month progression-free survival benefit for the group that got oligometastatic radiation. The trial was actually closed early. The ethics board didn't feel like it was ethical to continue the trial due to the benefits seen at interim analysis in the group that got SBRT. The second lung trial is the Iyengar. It's a phase 2 trial at a UT Southwestern. So this was published in 2018. Again, all patients, non-small cell lung cancer. They allowed up to 5 oligometastatic lesions that were extracranial. And interestingly, they did not count the primary tumor in the lung and the lymph nodes towards those 5. And that was 5 oligometastatic sites after these upfront 4 to 6 cycles of standard systemic therapy. They didn't allow brain mets, but 40% of the patients had previously treated brain mets, and that was allowed in the trial. So these patients were randomized to, after the 4 to 6 cycles of systemic therapy, either more systemic therapy or radiation to the lung primary and any nodal disease, as well as all oligometastatic sites, and then additional standard systemic therapy. What they found was about a 6.5-month progression-free survival benefit in the group that had radiation and standard systemic therapy versus the group that just had systemic therapy. The median overall survival has not been reached yet at this time. The phase 3, or the only phase 3 trial in the oligometastatic lung space, is the Sindus multi-center trial. And so these were patients that newly diagnosed stage 4 non-small cell lung cancer. The difference here, again, all EGFR mutated. They allowed 1 to 5 metastatic lesions, no brain mets. And again, similar to the last trial, the primary and the regional nodes did not count towards the 5 oligometastatic lesions. The radiation was done a little differently in this trial. They actually required it to be completed within 2 weeks. Both the primary lymph nodes and the oligometastatic sites were treated at the same time with a short 5-fraction SBRT regimen. So again, these patients were randomized to standard of care TKI therapy or local radiation to the primary nodes and oligometastatic sites, and then TKI therapy. A majority of these patients had 1 to 2 mets. They found an improvement in overall survival of 8 months and 7-month improvement in progression-free survival in the group that got radiation to the lung primary, the nodes and oligometastatic sites in addition to TKI versus TKI therapy alone. So the lung cancer ESMO guidelines, the only thing I really want to highlight is for stage 4 non-small cell lung cancer, for oligometastatic disease, really the recommendation, the standard of care based on a lot of this data is for systemic therapy and some form of local therapy. And they do point out here that local therapy can be either with radiation or surgery, and that should really be decided in a multidisciplinary setting. I'm going to touch on 4 oligometastatic GU trials. So the Stampede trial, the Extend trial, the Stomp and Oriole trial were 2 separate trials, but we really think of them together. They were the same patient population, very similar trial schema. And then the Italian Arto trial. So this first trial, the phase 3 multicenter Stampede trial, a lot of you may know about this. There were a lot of different trial arms, but we're only going to focus on the arm that included radiation to the prostate primary. So this was a randomized controlled trial. It was done across 117 hospitals in Switzerland and UK. There were over 2,000 patients. All patients were required to be newly diagnosed metastatic prostate cancer, treatment naive, with metastatic disease confirmed on some form of imaging. All patients received lifelong ADT, and they could start that 3 months prior to being randomized. So the 2 arms, they were randomized to either continuation of lifelong ADT or lifelong ADT and local radiation to the prostate. So this was done in either a 4-week course of radiation or a 6-fraction course of prostate SBRT. The target was only the prostate. So no lymph nodes were treated, no oligometastatic sites were treated based on, at least per this trial. And importantly is the differentiation between low metastatic burden and high metastatic burden. Low metastatic burden based on this trial was 1 to 3 metastatic lesions, no visceral mets. High metastatic burden was everything else. So what they found, the blue line here is the group of patients that got prostate-directed radiation in addition to lifelong ADT. The red line was ADT alone. They found there was a 22-month overall survival benefit for newly diagnosed metastatic prostate cancer patients who had low metastatic burden. Again, 1 to 3 metastatic sites with no visceral metastases, if they were treated to the prostate primary with either 6 fractions or 20 fractions of radiation in addition to systemic therapy. The next prostate trial is the phase 2 MD Anderson Extend trial. So this included 87 men, oligometastatic prostate cancer. They could be newly metastatic or recurrent metastatic, up to 5 metastatic lesions. Most were hormone sensitive, and they had good performance status. They allowed different forms of staging. They all had to have at least 2 months of hormone therapy prior to randomization. But you can see here that, over 50% had more hormone therapy than that. About 2/3 got ADT alone. 1/3 got ADT and abiraterone. Most of the patients had low volume metastatic disease. They allowed up to 5 lesions, but most patients had 1 to 2 mets. Most patients were staged with a CT and a bone scan, the rest with a PET scan. And really, they were asking the question, does adding metastasis-directed radiation to intermittent hormone therapy improve progression-free survival? So again, they had to have at least 2 months of upfront hormone therapy, but a lot of them had longer than that. Then they were randomized to either 6 months more hormone therapy or radiation to those 1 to 5 oligometastatic sites, in addition to 6 months of hormone therapy. And what they found was an improvement in median progression-free survival and the eugonadal progression-free survival when radiation was added to all sites of oligometastatic disease. The next 2 trials I'm going to talk about are the Stomp and the Oriole trials. Again, very similar trial schema. So these were both trials that included men newly diagnosed or previously diagnosed prostate cancer. They were treated with either local surgery or radiation in the upfront setting, non-metastatic at initial diagnosis, now with an asymptomatic rising PSA and imaging showing 1 to 3 oligometastatic lesions. The patients on the Stomp trial got choline PET CTs, and on the Oriole trial, they got PSMA PET CTs. Again, good performance status, previous local therapy with radiation or surgery to the prostate. They were randomized to either observation, and then they could get ADT at progression, or they got radiation to those 1 to 3 oligometastatic sites, and then they were given ADT at progression. This is the second trial, again, very similar, the Oriole trial. Some of the trial eligibility is a little bit different, but they still required patients to have previously diagnosed localized prostate cancer who had had surgery or radiation, now an asymptomatic rising PSA, 1 to 3 oligometastatic lesions. They were randomized to either observation or radiation to those oligometastatic sites. The analysis was really a combined analysis of both of these trials. And this was published back in 2022. They found an improvement in the median progression-free survival of 6 months when giving upfront radiation to 1 to 3 oligometastatic sites, and a significant delay to time to initiation of ADT. And this was in the STOMP trial. So the 5-year ADT-free survival, 34% in the group that got upfront radiation oligometastatic sites, 8% in the group that was treated with in the observation arm. So the last prostate trial is the phase 2 Italian multicenter ARTO trial. So these were patients that had castrate-resistant oligometastatic prostate cancer. Again, 1 to 3 oligometastatic lesions. Most of these patients had bone-only disease. 60% had 2 to 3 lesions, and this was a little bit more of a modern trial. So this was done, 90% of patients had some form of a prostate-specific PSM or prostate-specific PET scan for staging. So these patients, again, castrate-resistant prostate cancer, no prior systemic therapy. Most had PET scans, and they did exclude visceral metastases. So these were mostly bone metastases. So they were randomized to either hormone therapy or radiation to those 1 to 3 oligometastatic sites and hormone therapy. And what they found was that there was a higher chance of having an undetectable PSA at 6 months in the group that got upfront radiation to those oligometastatic sites. So 56% versus 23%. There was an improved overall biochemical response and an improved progression-free survival with the radiation. The median follow-up was only 24 months here. The median overall survival was not reached at the time of analysis here. So this curve on the left is the progression-free survival curve, with the red being upfront radiation to oligometastatic sites, and then the right is the overall survival curve. You can see they're starting to separate, but not at the time of the analysis. So this is the ESMO guidelines for prostate cancer. So for metastatic prostate cancer in the hormone naive setting, again, it's really important to differentiate between this low burden versus high burden of disease. Low burden for the purposes of this slide, either 1 to 3 or 1 to 5 oligometastatic sites. So for low burden metastatic prostate cancer, the recommendation, the standard of care really is ADT plus or minus chemotherapy, newer anti-androgen, and prostate-directed radiation. That's based on that STAMPEDE trial. And then for the patients that have a high metastatic burden, so really over 5 metastatic sites, the standard of care is really still just ADT or systemic therapy alone. And so based on the NCCN guidelines highlight this as well. And so one of the options for metastatic patients is for ADT with external beam radiation to the primary tumor, again, low metastatic burden patients based on that STAMPEDE trial. And in practice, what we often do, and I know Dario and I know Dennis do this a lot in Aurora and Boulder, is for newly diagnosed oligometastatic prostate cancer patients, they may get 2, 3, 4 months of upfront ADT, prostate-directed radiation with 20 treatments to the prostate itself based on the STAMPEDE trial. And then we'll typically come in and give SBRT in 1 to 5 fractions to those oligometastatic sites if they're an appropriate patient for that. I want to touch on one trial in the oligometastatic breast cancer space. So this is a phase 2 NRG BR002 trial. So this included 128 women, stage 4 breast cancer. They all had well-controlled local regional disease in the breast and nodes. They allowed up to 4 metastatic lesions, but no brain mets. They allowed 12 months or less of systemic therapy and no evidence of disease progression. And I think it's important to point out that for this trial, most patients had more indolent, less aggressive metastatic disease. So 60% of the patients had 1 metastasis, 80% had hormone receptor positive disease, 80%, about 80% had metachronous, so previously diagnosed breast cancer, now metastatic. Good performance status, well-controlled primary, no brain met, so they were randomized to either more systemic therapy or local therapy, radiation or surgery to those oligometastatic sites. Again, 1 to 4 sites allowed with systemic therapy. And again, it was similar to the other trial. About 75% of the patients got radiation, 25% of the patients got surgery. This was a negative trial. So at least at the time of analysis, there was no benefit in terms of overall survival or progression-free survival. This curve on the left is the overall survival. You can see that the curves overlap. The table on the right is the progression-free survival curve. Again, no benefit, but I think it's important to point out that this was at a median follow-up of just under 3 years. And I think the takeaway from this trial is that for patients that have a low burden of disease and excellent systemic therapy options, they probably won't show any significant benefit to oligometastatic radiation, especially within the first 2 or 3 years. We probably do need longer follow-up. The progression-free survival curves are starting to separate for ER-positive disease at that 3-year point. And really, based on this forest plot below, the benefit is probably the greatest in patients that have more than 1 metastasis. So patients that had 1 oligometastatic lesion that were treated with radiation actually had a decrement with getting radiation. The patients that had more than 1 metastatic site had an improvement based on this curve. All right, I'm going to turn it back over to Dario.
And I think we're at time, so for the purpose of time, I'll just stop. And we do have some clinical trials available within Boulder through multiple national cooperative trials. Happy to have people reach out, but we have trials in the prostate, lung, CNS setting. So feel free to reach out to me or Patrick Richard to talk more about that. But happy to take questions right now since we're at our end. I know the chat box, I think, was disabled, so I don't know if we had any questions sent in or anything, but if not, always feel free to reach out to us directly, email us, text us, call us. Always happy to talk about patient scenarios and get them in if they're appropriate. So thanks for attending.
Yes, thank you.
Thank you. All attendance was recorded and will be submitted for COPIC. Have a good day.